The concept of cure was pioneered by biology with the total therapy programs. And at the last meeting, we had the opportunity to listen to the results, the long-term follow-up results of two trials, the Spanish and the Italian trial, that were activated in 2005. Long-term follow-up now, 15 years. And in these two trials, approximately 1/3 of the patients remain disease-free for more than 10 years. Then this is probably a cohort of patients that has been cured. For me, to talk about cure in a disease means to have at least 50% of the patients disease-free at 10 years. And this is our goal. And in this meeting, I addressed this issue through different actions just to increase the cure rate in myeloma. One of the actions is to use the best possible techniques, the most sensitive techniques, in order to measure how the treatment efficacy was, in order to try to eradicate the tumor cells. And these are the MRD techniques inside the bone marrow and outside the bone marrow. Second, early detection and early intervention. In all the malignancies, breast, colon, prostate, early intervention is associated with an increase in the cure rate. Therefore, in myeloma, should be the same. And now we have already data that in the smoldering patients, we can either delay the progression into active myeloma. This has been demonstrated in 2 randomized trials with lenalidomide, one of them showing, the Spanish trial, a significant benefit also in overall survival. But the other possibility is not to delay progression, is to try to cure these patients with intensive treatment, but with the early intervention, early treatment in these patients. The subsequent action is to offer the best treatment to standard risk patients. I think a wrong approach will be to keep the best treatment for the high risk and not to use the best possible treatment for the standard risk. And finally, in the high risk, first of all, we need to identify all the high risk, because are not only the patients with high risk cytogenetics, also patients with extramedullary disease, patients that do not have a good initial response or have an early relapse are very high risk patients. And in these patients, we need to use experimental therapies as soon as possible. And all the immunotherapy that is now emerging in the myeloma field, the bispecific antibodies, the CAR-Ts, should be moved as soon as possible into the frontline therapy for the high-risk patients. And this was the concept that I am trying to apply to my own patients in order to achieve the cure rate for them.